Hello, future nurses and science students. My name is Madame Uterus, though you might also hear me called the womb. I am a hollow, thick-walled, pear-shaped muscular organ located deep inside the female pelvic cavity, sitting comfortably right between Mr. Urinary Bladder in front of me and the rectum behind me. In your maternal newborn nursing lectures, clinical rotations, and proctored assessments, you will hear my structures and disorders described using the root words hystero or metro, like hysterectomy, endometriosis, or metrorrhagia. If you see those terms, it's all about me. While I am normally quite small, about the size of your clenched fist, I possess a mind-blowing ability to expand to over 500 times my original size during pregnancy to house, protect, and nourish a growing fetus, and then generate the most powerful muscular contractions in the human body to push that baby out into the world. Anatomy, the structural regions. To pass your maternal newborn structural assessments, you must break my anatomy down into three primary geographic regions: the fundus, the body, and the cervix. 1. The fundus. This is my dome-shaped upper roof, sitting safely above the entry points of the fallopian tubes. The clinical target. In postpartum nursing, this is your primary assessment target. You will physically palpate the patient's abdomen to feel the fundus to ensure it is firm, midline, and contracting down normally to prevent maternal hemorrhage. 2. The body, corpus. This is my large central middle section. It encloses a triangular internal cavity where an embryo implants and grows. It is supported in place inside the pelvis by a web of tough bands, primarily the broad ligament and the round ligaments. 3. The cervix, the gateway. This is my narrow, cylinder-shaped lower neck that projects downward into the vagina. It acts as the ultimate gatekeeper. The cervical mucus. Under the influence of estrogen and progesterone, the cervix produces thick mucus that can either block bacteria and sperm from entering, or thin out to act as a watery highway for sperm during ovulation. Effacement and dilation. During labor, the intense contractions of my upper body pull up on the cervix, causing it to thin out completely. Effacement, and open wide to a diameter of 10 centimeters. Dilation, so the baby's head can pass through. Microanatomy. The three layers of the wall. This is a massive favorite for nursing pharmacology, physiology, and pathology exams. My thick uterine wall is made of three distinct layers, each with a completely different cellular job. 1. The perimetrium, the outer shield. The thin, transparent outermost serous membrane layer that covers my exterior surface, reducing friction between me and the surrounding pelvic organs. 2. The myometrium, the muscle engine. This is my thick middle layer, making up the vast majority of my mass. It is composed of three interlocking woven layers of smooth muscle fibers. How it works. These muscle fibers are completely involuntary. During labor, they respond directly to the hormone oxytocin released by the pituitary gland. Oxytocin causes these smooth muscles to contract rhythmically and violently, pushing the baby downward against the cervix. 3. The endometrium. The inner velvet lining. This is the highly vascular, plush inner mucosal lining facing my internal cavity. It is split into two sublayers that respond continuously to monthly hormonal cycles. Stratum basalis, the base. The permanent inner layer that stays behind and doesn't change. Its job is to grow a brand new top layer every month. Stratum functionalis, the functional layer. The dynamic temporary layer. Every month, surges of estrogen and progesterone cause this layer to swell with blood vessels and nutrient-rich fluids, preparing a perfect bed for a fertilized egg to implant. The cycle. If pregnancy does not occur, the corpus luteum dies, hormone levels crash, and this functional layer undergoes ischemia, breaks apart, and sloughs off through the vagina. In clinical practice, you know this monthly shedding as menstruation. The uterine cycle, the three phases, managed hand in hand with the ovaries, my endometrium marches through a continuous monthly cycle to prepare for potential pregnancy. Phase 1, the menstrual phase, days 1 to 5, triggered by a sharp drop in progesterone. The blood vessels supplying the stratum functionalis constrict, starving the tissue of oxygen. The dead tissue sloughs away as menstrual flow. Phase 2, the proliferative phase, days 6 to 14, driven by rising levels of estrogen coming from the developing ovarian follicle. The stratum basalis goes into overdrive, multiplying rapidly to rebuild the plush vascular functional layer. Phase 3, the secretory phase, days 15 to 28, driven entirely by progesterone secreted by the corpus luteum after ovulation. The newly rebuilt functional layer swells further. Its glands begin secreting glycogen nutrients, and it becomes a highly welcoming environment for an embryo. Common uterine pathologies. When smooth muscle grows out of control or lining tissue escapes its boundaries, severe clinical symptoms surface. 1. Uterine fibroids, leiomyomas. Benign, non-cancerous tumors that grow inside the smooth muscle layer of the myometrium. The pathophysiology. These smooth muscle tumors are highly sensitive to estrogen. They can grow quite large, warping the shape of the uterine cavity. The presentation. They cause heavy, prolonged menstrual bleeding, menorrhagia, severe pelvic pain, cramping, and pressure on the bladder, leading to frequent urination. 2. Endometriosis, the stray lining. A painful condition where fragments of the vascular endometrial lining tissue somehow escape my cavity and begin growing on structures outside the uterus, such as on the fallopian tubes, the ovaries, or the outer wall of the intestines. The problem: even though this stray tissue lives outside the womb, it still possesses the exact same hormonal receptors. Every month, when estrogen and progesterone rise and fall, this stray tissue outside the uterus thickens, breaks down, and bleeds directly into the pelvic cavity. Because that blood has no way to exit the body, it causes intense localized inflammation, scarring, agonizing pelvic pain, especially during menstruation, and can lead to infertility. Image demonstrating endometriosis, showing endometrial tissue implants growing on the exterior surfaces of the ovaries and fallopian tubes. 3. Postpartum uterine atony, the boggy uterus. Immediately after a mother delivers a baby and the placenta detaches, the blood vessels that were feeding the placenta are left wide open, bleeding profusely into my cavity. The safety mechanism. Normally, the myometrium must contract down firmly like a tight, giant muscle fist to physically squeeze those bleeding vessels shut, acting as the body's natural living ligatures. The crisis: if the myometrium becomes exhausted due to a long labor or a very large baby and relaxes, it enters a state of uterine atony. The uterus becomes soft, spongy, and relaxed, clinically referred to as a boggy uterus. Without that muscle contraction, the open vessels will bleed unchecked, leading to rapid, life-threatening postpartum hemorrhage. Critical nursing assessments and implications. The Fundal Assessment Protocol. When caring for a patient in the immediate postpartum period, you must perform regular fundal checks. You will place one hand at the base of the uterus to support it and use your other hand to palpate the abdomen to locate the fundus. The target. The fundus should feel firm, round, and located right at the midline of the umbilicus. The boggy uterus intervention. If you palpate the abdomen and the fundus feels soft or boggy, your very first highest priority nursing intervention is to perform a firm, circular fundal massage. This manual friction stimulates the smooth muscle fibers of the myometrium to contract down, tightening the muscle fist and stopping active postpartum bleeding. The bladder deviation trap. If you perform a fundal assessment and notice that the fundus is soft, elevated high above the umbilicus, and deviated over to the right side, the uterus is not the primary problem. Mr. Urinary Bladder is full of urine and physically pushing the uterus out of place. A displaced full bladder prevents the myometrium from contracting down fully, which can cause an atonic hemorrhage. Your immediate nursing action is to have the patient void on a bedpan or insert a urinary catheter to empty the bladder and then reassess the fundus.